So good afternoon from the Montreal Heart Institute. My name is Anita Asgar. I'm joined today by my surgical colleague, Dr. Raymond Cartier, and my fellow Marcel Santello, and our team of nurses, our anesthetist, Dr. Marco Julien, Danielle, and Lucy. So we have a case today for you of a TAVR, a patient with severe aortic stenosis. So Marcel's going to present the case, and then we'll talk a little bit about the procedural strategy.
Sure, thank you. Good afternoon. This is a case of a 45-year-old male with severe symptomatic
85.
85, yeah. What did I say?
45.
Sorry. Sorry about that. 85-year-old male with severe symptomatic aortic stenosis. His medical history is notable for diabetes, hypertension, and dyslipidemia as risk factors. He also has a atrial fibrillation, which is anticoagulated with Xarelto. He already has a permanent pacemaker in the past, a DDD, and he's also clinical renal impaired with creatinine around 130 micromoles per liter. His current history is about progressive dyspnea on exertion and also pre-syncope. He has as well some mild chest discomfort on exertion. So the workup leading to this case, his EG had base ventricular rhythm. His transthoracic echo showed just mildly reduced ejection fraction at 48% with a non-dilated left ventricle. His estimated pulmonary systolic pressure is 43, and his mean aortic gradient was 43 millimeters of mercury with a calculated area of 0.86 centimeters square. He had 2 out of 4 mitral regurgitation and mild atrial regurgitation. His coronary angiography showed no significant coronary artery disease, and his right heart cath that was done previously showed a pressure, RA pressure over 9 and mild pulmonary hypertension at 59/16.
So I'll just talk a little bit about the exam. So we, like most people, we do all our workup with 3 Mencio. So this is our CT scan. So you can see the image on the far left is the aortic annulus. I can't read the images from here, but I think we had an area of around 510. You can see the sinuses that were measured, as well as the sinotubular junction. I put an image on there for you, just to show that the sinotubular junction is a bit calcified. It measures around 30 by 29. With an area of 510, we're targeting a Sapien 26, so an S3 26 millimeter. So next slide. So these are our angulations. We do all our angulation planning by 3 Mencio. So we've got a LAO of 20, a cranial of 6. We do tend to do in the 3 cusp, not necessarily the 2 cusp, but we do both angulations. Next. And this is our vascular access. So we already have vascular access, but you can see he's got quite large peripheral vessels, not significantly calcified, and the bifurcations are both low. So next slide. So in terms of how we're approaching this case, vascular access, clearly femoral. We do ultrasound guided puncture for all our cases. We use the MANTA for closure, so we're going to show you that at the end. And we do the measurement. So right now what we've done so far, we've got our E-sheath in the right femoral artery, and we've got a catheter in the left femoral artery. In terms of a choice of TAVI valve, obviously this patient could have had either an Evolut or a Sapien. He's got good vascular access. He already has a pacemaker, so he would be ideal for both. We decided to choose an Edwards here. And so what we're going to show you live is crossing the valve, putting in the valve, and hopefully management of the vascular access. So this patient was discussed with a heart team. Our cardiac surgeon scrubs with us for all our cases, and he and I are going to do this case together. So we're going to start. So maybe just I'll have the lights low. Si on peut juste baisser un peu les lumières. I'm going to cross the valve with an AL1. So we're going to go up. So up we come. And so we're doing this case in the cath lab today. Tend to do these mostly in the hybrid room, but today we're going to be doing this in the cath lab. So maybe we can just play the aortogram that we already did. You can see the aortogram. We have large sinuses, sort of a central opening. The mean gradient, as we said, was 43. So we don't anticipate having to do a valvuloplasty in general. We don't. But we'll see how difficult it is to cross, and if there's any challenges, obviously, to advance our catheters. Ideally, I'd like to see the jet. I don't actually see it. Trying to stay central.
Crown down, c'est ça.
Not
Ouais.
quite there.
Regarde, là, du mauvais bord. Là.
Maybe the AL1 is not our best catheter, but we'll see. Oh, and we're across.
Wow.
So finally, it's not so bad, the AL1. So in terms of equipment, we are going to be using a Safari Extra Small. And as I said, unless there's any particular challenge, our plan is not to pre-dilate here. So maybe just, est-ce qu'on peut juste centrer, s'il te plaît? Juste pour avoir plus de ventricule. L'autre sens, un peu plus. L'autre sens. Parfait. We're just going to advance. An exchange wire. We like to measure our gradients before, and we like to use a pigtail to get a nice position. So we have our wires in a good position. I have a little bit of arrhythmia. How are we doing with the valve?
Doing good.
Okay. Well, so Daniel is in the meantime, he's crimping our valve for us. So all these patients are discussed in a heart team. Obviously, he's 85. He's at his age, with the data that we have from partner 2 and 3. He certainly is what I would consider more intermediate risk. He's a good indication for a TAVI. He's a very independent patient. Nice solution for him. And with a pacemaker, probably would go home tomorrow after his echo if all goes well. So we're coming up with a pigtail catheter. Pull on your wire a little bit for me, please. Okay. Just to get a gradient. Perfect. So our valve is ready. We're going to get a gradient.
That's fine.
Okay. We're going to see what our gradient is here. Okay, pressure.
Yep.
So he's in a paced rhythm. Got an end diastolic pressure at around 18. And we'll just see what our gradient is. So he's not intubated. He's sedated. Our anesthesia team is here monitoring him. Qu'est-ce que ça vous donne comme gradient?
Valve est prête.
Okay, so we've Colby? Okay. So we've got a mean gradient of around 20. He's sedated. Perfect. So our valve is ready. We're going to go ahead and put our Safari wire in. We tend to pace on the wires. We don't put in a temporary pacemaker. We're going to pace on our Safari wire. Oh. So this is a Safari Extra Small. Okay, Marcel, si tu veux m'aider. Okay. Est-ce qu'on a un ACT? Perfect. Okay. So our anticoagulation is good. As you can see, we've got you may or may not be able to see, we have a small needle in the skin. We have the little alligator clips, and we're going to pace on the Safari wire. Okay. Raymond, si tu veux être ici? Okay. So. All right. Moi, je vais garder le scopie. Okay. All right. So we're already across. That was a lot faster than we thought. We're coming up with our valve. So this is an Edwards 26. We're going to go nominal for this. Again, things you want to watch out for on the scan. Do you have calcification? Where is the calcification? What is the optimal view? Okay, just 1 second.
Right.
And then obviously vascular access. So all the planning is really done on CT. And we already had a coronary angiogram, which we know is normal. Okay. Just give me 1 second. Okay, go ahead. You pull the loader back. Just give me 1 second, please.
Okay.
Pull this. Okay. All right. Up you go. OK. We go to... Bon, mettre ça en AP. Oh. Ouais. faire attention, là. C'est super bas. Okay. Just advance a little bit. Remo, advance a bit. Okay, we're gonna load this now. As you can see, we're just gonna load the valve onto the balloon. Tâche le guide, s'il te plaît. All right, we're just gonna bring it back. A little bit more cranial. Plus de cranial, s'il te plaît. On n'est pas bien aligné. Monte le tube. Okay. Pas trop, là. Descendre un peu. Okay. Okay, so we're better aligned. We're gonna load this on the balloon. Just bring in the balloon back. Marcel, if you want to be here just in case my wire needs some work. Okay, I'm gonna bring it back. Just gonna load it up a little bit more. Okay,
Ready?
so just advance my wire a little bit for me. Okay, donc, we'll just go back. On peut retourner dans notre incidence, s'il te plaît. We'll go back to our view, and then we're gonna follow the device up around the arch, do some flexion. C'est 14. Okay. Monte-moi en haut, s'il te plaît. Oh, just get en centre, oui. Okay. Vas-y. We're going to flex as we go around. We're going to stop before we cross the valve just to verify our pacemaker. Okay, we can stop here. I'm going to connect our pacemaker. So again, we're pacing on the safari wire. Can we test the pacemaker, please? Okay, so pacing off. Okay, so we're going to try to cross the valve. I'm just going to myself here. Okay, yep, ready to go.
I'm going slow.
Okay. Just
remove the flex.
Yeah, I'm just not sure we're completely crossed the valve. I think our pigtail is a little high. Yeah. You can see we haven't really crossed the valve yet. There we go. So keep coming. I'm going to remove some more flex. Yeah, we're just going to see the patient is quite stable. The blood pressure is good. Perfect. Okay, so we're just going to position. So we've come up a little bit. Let's try to advance a bit more.
Okay, sounds good.
Okay, so we'll do an angio here.
Sure.
Marcel, if you can manage that for me. We'll do an angio, then we'll pull back the pusher. So I'm a fluorocinate. So we're still high, huh? So our pigtail is a little bit misleading. So we're going to advance our pigtail. Okay. So I would advance the system more. Really want to put that marker at the level of the annulus. Just advance a bit more. It seems to go up as soon as we release it. Okay, I'm going to pull the flex off. I think we'll take another angio. Sure. So the flex is off. We'll take another angio here. Okay, so that's much better, I think. We got a lot of AI right now, so we're going to pull back the pusher. So you just let me pull the pusher back. Gonna pull that all the way back. All right, we're gonna get ready to deploy. So, fluoro. Okay, so it'll be pacing on. We'll start at 140. We'll do dog bone. You're gonna inject.
Yeah.
And you're going to pull the pigtail?
Sure.
Okay, everybody ready? All right. Pacing on. Okay, I'm going to dog bone. Inject, please. Okay, pull the pigtail.
Good.
Full balloon. 1, 2, 3. Balloon down. Pacing off, please. Okay, and just save this fluoro for me. Okay, he's recovered. We're going to have a look here. I'm going to pull back the system. Just going to take all the flexes off.
Yeah.
System is coming back. Okay. We're going to take this out. Pace is disconnected. Okay. All right, so we're going to take out the system, and we're going to do an angio and see where we are. Check our pressures. So I'm bringing the system out. Hold on a second, I'm a little caught here. All right, do you want to pull the rest of that out? Okay,
Yeah.
we'll just watch our wire. Just sensible. Okay. Okay, I'm just going to watch our wire.
Yeah.
Yeah, perfect. Okay. Je prends la pigtail, s'il te plaît.
Oui.
All right, so we're going to get some invasive hemodynamics to have a look. All right, here we go. Great. Okay, so we'll just pull this out. I'm just going to connect you up. Flush.
Oui.
Okay.
That's the other picture.
Yeah, let me pull the pigtail back just a little. This one. There we go. There we go. All right, I'm going to check. Let's just check our
Okay.
zeros.
Yeah.
On peut vérifier le zéro, là. Il y a une qui est pas bon. Check our zeros and we'll get a gradient. Perfect. That's more like it.
Yeah. Perfect.
All right, so je prends un guidji régulier. We're going to take the pigtail out, do a final angiogram, and then we're going to show you how we close the vessel with a MANTA device. All right.
On va faire l'autre. On va la faire.
OK, c'est parfait. On va laisser ça là.
Okay.
3 of gradient, perfect. OK. 30 à 15 pour l'aorto. OK, flush. Parfait. OK, ready?
Yes.
Cine.
Just le pousse un peu.
That's perfect.
Perfect.
That's perfect. We like to leave ours not too high, but this is perfect. This is sort of a 80-20.
Yeah.
We see the sinuses are big. We see good flow in the coronaries. We're far from that sinotubular junction, which we know is calcified, so that's perfect. So the next step, we're going to go into AP, and then we're going to get our vascular access management started. So we always cross over. What we like to do is close the manta on ultrasound, so we're going to show you that. Because we like to see the anchor, and we like to see the collagen plug coming down. Je prendrai le stiff.
Stiff ici.
Oh, stiff dans l'autre. Mais donne-moi le 35.
35.
Je prends le stiff dans l'autre.
Oui.
We're going to cross over for a mammary catheter and cross over onto the right side. I'm going to disconnect the pace. He has a permanent pacemaker anyway. Here's the needle. Je prends des compresses mouillées, s'il te plaît. Merci. So it's amazing how TAVI has evolved over the past 10 years. Used to be a day-long event and we do 2 cases a day. Now we're doing 4 cases a day. And we could do them in the regular cath lab. All right, so we're coming up. Juste montre-moi la bifurcation en bas. OK, c'est beau. Reste ici, s'il te plaît. Just prends le bistouri. So we're going to just bring our other sheath down. OK.
Faut te le retirer.
Oh non, pas encore.
Non, non,
Je
non,
vais
mais
mettre...
quand on commence.
Ouais. Je vais mettre the... I'm going to put the stiff. So we'll put our stiff wire in. I like to close the manta on a stiff. It's not always what the company recommends, but I find it's much, much better. So you can leave the sheath in. I'm going to just take out the And I'm going to put the dilator in. So we'll put the dilator back so we don't get any bleeding from the E-sheath. Okay, so we'll take the dilator of the E-sheath, please.
Yes.
Okay, go ahead. Great, thank you. All right, so we're going to put the dilator back in. We'll just have it coming out just a little bit into the aorta. That's perfect there. You can bring the whole system back a bit. Suis-moi en bas. Keep coming. Your dilator's out a little bit more than I would like. Okay, that's fine. Keep coming down. Perfect. Stay there. I'm going to try to get beside you. There we go. Suis-moi en bas. Okay, you can... Oh. Hold on, we're going to just get around the corner. Just try to get my wire out a bit more. Doesn't want to go.
Recule un peu.
All right, I gotcha.
Nice.
All right, so we're down.
Perfect.
We're going to leave that there. We're going to take some pictures after our manta. So we're going to get our ultrasound back. We're going to have a look at the vessel. We're going to get ready for the manta. Let's suppression. Can we show them the ultrasound machine? Perfect. We like to close under ultrasound, and we do measure the manta as per the IFU before. So here we measured 5 centimeters, but I still like to close on ultrasound because I can actually see the anchor coming up and I see the collagen plug coming down. So when you see well, it's very nice.
See?
So I'll show you a little bit about what that's going to look like. So it's worth the extra 5 minutes it takes to do this, I find. And we have to give protamine. So we're going to do this. And then when we're going to get ready, we're going to give protamine. Okay, so you can sort of see my vessel there. J'ai juste changé le gain un peu, c'est trop blanc. Ok. Ouais, c'est pas super beau, hein. Okay, can we give protamine, please?
Il la prépare.
Okay, so we're gonna give some protamine. Try to get a better image for you. Okay, so we see our wire going down. We'll try to get it in a long axis so you can see better. Okay, so we'll probably see a little bit easier once the sheath is out. So what we'll do is we'll take the sheath out and we'll put the manta sheath in. So we're going to advance our wire. Okay, so you can take that out. Keep the wire in. Perfect. We'll take the manta sheath. So always important to measure before so you know when you're going to open up the anchor. The ultrasound doesn't obviate the need to follow the steps. So we're going to go all the way in and we're hubbed out. So now we're going to just look again with our echo before I take out the dilator. See if we see a bit better. Possible to move my screen so I can see a little bit better. Je vais tasser mon écran vers là, là. Je vois super mal. Ok, ça c'est mieux. Sometimes after with the sheath in, we don't see as well. Okay, what we'll do is we'll take out the dilator. I don't know if you want to come here and do the echo for me. On peut juste tirer la table parce qu'on va pas faire endoscopie actuellement. Okay, so we're going to take out the dilator. And Marcel is going to keep his eyes on the artery while we do this. Okay. Je prends la manta, s'il te plaît. The stiff wire does cause a bit of bleeding in the valve. You have to centralize it so you don't have too much issue with that. Okay, we're going to go in. And we want to click it. Oh, I got my towel in there. Hold on 1 second. All right. There we go. 2 clicks. Okay, so now you're going to try to find me.
Yeah.
Importance here is to have the right angle and not for him to not press too much, because I did measure before, so I don't want to distort the skin. If you turn it
Yes.
just to see if you can get a long axis. Oh, you're almost there. Let me see if I can help you there. We don't want to push down too hard.
There you go. The sheet going in.
Now, you see, I can kind of see the wire a bit there. It's just so you see the wire track coming down. Now, if I just turn it, normally I should be able to see it. Well, if we don't see it, we're going to have to look after. I'll let you hold it there then. What you don't want to do is put too much pressure on the skin so that it changes your measurement. So we said 5, so we're going to go to 45 degrees, and we're going to come back. So 10, 9, 8, 7, 6, I'm at 5, anchor is out, and we're going to pull back till we see the green. We see the green, we're going to push forward, we get the red, and we got a click. Je prends les compresses sèches. Merci. Okay.
Sur la gueule.
Yep. So we can pull out the wire now. We've given our protamine. We don't have any bleeding. We'll see if we can see. Okay,
That's
so you
there.
see the
Can you see
artery.
the anchor there?
That looks like the anchor. I just don't see the collagen plug. I think it's there.
There.
Yeah.
Yeah.
Actually, that's beautiful. It's a beautiful image.
Yeah. Anchor.
That is
anchor and
very
collagen.
nice. You see the anchor right up there. You see the plug. It's beautiful. So we're going to take an angio as well. So if I can just have some dye and an angulation, please. Fais-moi le
Est-ce que le
colorant et
bistouri,
anguler l'affaire, s'il te plaît.
est-ce que tu veux couper ça ici?
Moi, je vais le couper après. Là. Oups, trop bas, trop bas. Monte en haut, encore en haut. Faut que je vois mon cathéter. Okay, all right. I'm going to do an angio here. Okay, so you can see that little radiopaque marker is the marker of the Manta device. We see no leaking around it. It's exactly what we saw in ultrasound, that little bright piece that we saw in the collagen plug is on the outside. It's a beautiful image. We're going to cut here. We can just pull the table. We can put a little suture in the skin. And we can put an angio-seal on the other side.
It's nice.
Yeah, it's fine. Just je prends les compresses sèches.
So that's it.
So if we can just go back to the slides, maybe we can talk a little bit about what are the other issues with the TAVR. I'll let you put the angio-seal on
Sure.
the other side. So we can go back to our slides for a moment. We'll talk a little bit about what are the issues with TAVR. So TAVR has become relatively straightforward procedure right now, as you can see. That's taken us less than a half an hour to do, from start to finish almost. We cheated and did the vascular access before. And you saw us how we manage the vascular access. So it's an ultrasound-guided puncture, and it's also an ultrasound-guided manta closure, which we showed you, and you can see very nicely. So if you go to the next slide. So this is our procedural plan. So right femoral access for the valve, as you saw, we crossed the valve, Safari guide wire, and the Edwards valve. And we just showed you our crossover and closure with the Manta device. Next slide. So maybe we have some time, we can discuss a little bit. You know, TAVR right now, again, is pretty much a straightforward procedure, but relies very heavily on imaging. And so developing an imaging expertise, particularly with CT scanning, understanding using using programs like 3Mencio to help us really plan the procedure, evaluate everything. And as TAVR operators, that's our responsibility now. We do all of that and we choose our valve, and then we manage after the fact. In terms of management of vascular access, to be very frank, the Manta device has really changed dramatically the management of these patients. in terms of it's lowered our vascular complications incredibly. And these patients can be mobilized very quickly afterwards, and we've done same-day discharge for these patients. So I think that's really the future for TAVI. The other issue is obviously antiplatelet treatment. So this patient, he's anticoagulated already
Sorry, Otto.
for atrial fibrillation. And so the question is, do you add another antiplatelet to that, or do you leave these patients on their NOAC? The Canadian guidelines recommend that if they're not on anything, you give them aspirin, so single antiplatelet, as per all the studies that we've seen so far. We don't give dual antiplatelet therapy unless the patient has had a recent PCI. If a patient is already anticoagulated, we have a tendency to follow what we would do with a patient having PCI and atrial fibrillation. So we would treat them with Plavix or clopidogrel with their anticoagulation for 3 months, and then we would stop it. It's difficult to know what the best thing to do is. We do know that the NOACs alone haven't showed any benefit, particularly across the board. But we feel that adding an antiplatelet for 3 months is a reasonable thing if the patient has no contraindication. So that's our case. I don't know if there's any questions or anything that needs to be just, on Slido that we can answer. If not, we're finished. You've already put your angioceal, so we're done. You can see the groins, and he's gonna be the sedation. We're gonna lessen the sedation. We're gonna get him up, and he's gonna come out of the room and go up to his room in about an hour. We're gonna keep him in the recovery room for about an hour just to keep an eye on him, and he'll go back to the floor. So these patients don't necessarily need intensive care. Obviously, they can go back to the floor. But we do keep him down with us for about an hour just to make sure there's been no complications. I don't know, Raymond, if you had any comments as a
No, it's
surgeon.
a very nice procedure. You did a very good job. I'm quite amazed every time we use the Manta to see how much efficient it is and how much we preserve the vessel too. The caliber has not changed.
Right, there's no stenosis. A lot of what we used to
And
see sometimes with tuberculosis is with some stenosis, some.
it's an incredible job.
No, it's a beautiful image. So, yep, that's where we are.
Thank you
So
very much.
I think our next room is hopefully going to be ready soon to get started. In the meantime, we're just going to finish up here. Okay. All right. Okay. All right. Thank you,
Bye.
everyone, from the Montreal Heart Institute. Have a good day.
Bye.